everyone. Welcome to the main event. My name is Joe Tillman, and you're watching the Hair Transplant channel only on YouTube and maybe listening on some sort of podcast outlet. Once I upload these to a podcast outlet, we'll see how that works out. If you're new to the channel, don't know who I am, my name is Joe Tillman. I've been in the hair transplant industry professionally for 20 years. Now, what does that mean professionally? I've always wondered about that. But what it means is I've worked for clinics. I worked in clinics for 11 years of my career at a very high level, working with some fantastic doctors as a consultant, but also as the face of the company when I was working in one particular clinic, but spending a lot of time in surgery, not just for myself, because I've had 10 hair transplants. I had 8 transplants with this clinic, but absorbing information. I love hair transplant surgery. It's very fascinating to me. The entire process, the surgery itself, not just the recovery and the results. It's a surgery that really gets me interested. In another life, I would be a hair transplant surgeon. So, but yeah, I'm also a repair patient, having had my first 2 hair transplants almost 30 years ago that brought me into the industry as a repair patient 9 years later. And since I've done that, I've been very blessed to be able to strike out on my own and start working with some fantastic clinics around the world, some fantastic doctors. I actually go to these clinics and I review them using my experience, my aesthetic, and what I feel are pretty high standards that clinics that I want to work with need to meet. And it doesn't mean that all the clinics I work with are the absolute best in the world, but they are certainly high tier and are putting out some just great results. And it's not just about the surgery. It's about how they take care of you. It's about going into the clinic and feeling safe that something bad's not going to happen. I could go on for hours about that. But speaking of doctors and clinics that do a great job, I do have a doctor joining us, and that doctor would be Dr. Özlem Biçer. I think I said your name correctly. Doctor, how are you?
Hi, fine. Thank you. How about you?
Very good, very good. Let's see, make sure this is, make sure the broadcast is going forward. Hold on just a second. I'm just making sure, looks like, oh, there we are. Okay, yeah, just making sure that the broadcast was getting out there. Dr. Bisher is just, I think she's a fantastic doctor, and so I'm glad to bring her to my audience. And the original idea was for her to answer phone calls, but I think I'm having an issue still. I will entertain one phone call just to see if it's working. The problem isn't her hearing you, it's you being the caller hearing her. So if it doesn't work out, then we will switch over to the chat function, which is fine. It's a very easy thing to do. But Doctor, let's just talk a little bit before we get our first phone call. You just got back from Los Angeles. What was going on, and what happened? What's going on in LA for you?
Now, last week we had a Los Angeles hair restoration course for all over the world, and there was some presentations, live surgeries, cadaveric workshops. And I had 2 presentations there. We tried to train the new colleagues just for the society. We shared the tricks of the hair transplantations, important points. Every doctor who attends the Congress and who are in the faculty, we tried to share all of our experience with each other. And we learned so much. We enjoyed so much. It was great to be with the colleagues, I have to say. Every time I enjoy so much when I'm in the society, and really we have wonderful colleagues in the world, so many experience. We shared every detail with the new guys. So I love to be there. It was a good experience for me, and I guess also for them. Really, I feel very happy when I am with my colleagues in the meetings. It's good for my soul, first of all. I have to say.
That's good. I understand that, and having been to many conferences myself, and the last one I was at was actually with you, not with you, but we got to meet up in Istanbul right before I actually went into your clinic for review. But I need to ask you, at this particular conference, I don't see this a lot at. I don't want to call this a conference. It was more of a workshop because it was a lot of
Yes.
live surgery going on. Were there any discussions in the? Sorry, got a call coming in. Hold on a second. Were there any discussions? Not so much about surgery, but as clinics, what you can do to better manage patient expectations and taking care of the patient throughout their journey post-surgery. Was there any discussion about that? And if so, can you give us a bit of, shed a little bit of light on that?
Not in this meeting, not in this workshop, but in the previous workshop in FU Europe, I think 2021, and maybe in Global Hair Loss Summit, I had a presentation related with the patient psychology, and
I remember
the
that.
base of the base of the patient psychology is the understanding of the expectations of the patient and take the expectations in a realistic way and try to inform the patients. And this is what we have to be very careful on.
Yeah.
So also there was not a specific discussion on it, but also in some presentations we mentioned on it, but we know that all of the expectations are important. We are not God. How much of them we can give the patients, we can afford it. So we have to clarify these points, and all the doctors are agree on it that this is very important for this for the successful of the surgery.
Right. Right. I feel like it's important to talk about these things because too many times I see the focus being on not just the surgery, but there are discussions about how to market yourself to patients in some of these workshops and conferences. And while it's important to be able to understand how to get the word out about your offerings, I don't see enough of the what you're talking about, the discussion of the psychology of the patient. I think it's really important to cover those things. I really liked your presentation at Global Hair Loss Summit on this subject, and I'm only asking about it because it just kind of flipped a switch in my mind about this. I think it's important to also and give me your opinion on this. I think it's important not to pander to patients as far as, I don't want to say misrepresenting, but using the easy photos of people that aren't even patients with full heads of hair saying, get your hair back and, come to our clinic and we can help you with this. And it's almost false advertising where you're putting the image of someone that's not even a hair transplant patient, a model, into, like, say, an Instagram ad or something like that. What's your feeling on that? How do you feel about those things?
Now, what I can easily share with you, if you check my Instagram page, in every post, you will see some sentences, and it is written that this is not an example of your surgery. This is not an offer for your surgery. This is only the image of this patient before and after photographs, and there is no guarantee related with the result. As a doctor, we have too many responsibilities. We know how riskful job we are performing, and we have no chance to give any guarantee, but we can give the guarantee that we are going to do our best. That's all.
That's
but we
what I
know
like to
that
hear.
everything we know that everything during the surgery may go bad, may go good, but we know how to handle. We have B plans, C plans, D plans for every emergency. That's very important
Yeah.
because now, as a patient, they are not aware of how serious job we are performing. But we know what we are doing during the process because we give local anesthesia. We know how many complication risk we buy during the surgery,
Yeah.
and we have to know how to handle it. So what is important for me, if a patient comes to my clinic, I know that he has father, he has mother, he has son or daughter or wife. So he has a family. He is not alone. And he has some wishes, expectations, and some opinions in his mind. What is in my mind? First, I want him to come to my clinic in a healthy way. The second, I want him to leave my clinic in a healthy way. So my priority is this. I know that I'm going to have some risk and he has to come to my clinic healthy and he has to live healthy. The second, of course, I have to focus on the result. I have to do the best transplantation to him just for his case. Every case has different advantages and disadvantages. Some of them, their donor areas are great, their density is great, the recipient area is small, so the approach of this patient is completely different. Some of them, as you know, Norwood 7, and we have to clarify the expectations, and I try to share how much of his expectations I can give him. So yes, results are important. The safety and the, how can I say, the approach, the philosophy, I guess, is more important for me because you can upgrade the results. You have chance. Especially last years, we have a lot of opportunities just to increase the level of the result. But if we do some critical mistakes, we have no chance to go back. So, in my opinion, the priority is safety. Second, the result. The third point is aftercare, because surgery is not finished when you perform it. The result takes 1 year. You have to give attention to patients at least for 1 year, because in that case you have chance to get the maximum result. Otherwise, if you don't follow your patients, if you cannot take under control any complications or any risk factors, it will affect your result directly.
Yeah.
So this is a whole process, and it takes at least 1 year. In my clinic, generally it takes 2 years per patient. It means that they touch in contact to me at least 6 months before the surgery. We do consultations, we prepare the file for him, we do plannings, surgery day, then 1 year after the surgery, last results, maybe touch-ups, maybe second sessions. So it's a long journey.
Yeah. It's certainly a long journey. And one thing that you said at the beginning of your comments is the only paraphrasing, but it's almost identical to what I say, is that you're not making a guarantee on the outcome. The only guarantee you can give is your best effort. And I am absolutely on board with that. I've been saying that for years, that no patient should trust a guarantee, because a guarantee should not be given except for the best effort. That's the only guarantee that a clinic should give. And I appreciate you saying that. And for the listening and viewing audience, we didn't talk about this before we went on air. And if you're a follower of my channel, subscriber to the channel, and follow my website or my Instagram, you know that I've been saying that for a long time, because it is the practice of medicine. Like, there's so many variables involved in surgery, they can't be guaranteed. But the best effort can be. That they will guarantee their best effort. It doesn't mean perfection every time. And it's always nice to hear doctors like Dr. Bisher say such things, because you as patients, consumers, need to be aware of that. And so thank you, doctor, for stating that, because I think it's really important. Before we move on, we did have a call and they hung up. I had them on hold. If someone can give us a call, the toll-free number, 833-563-4247. Let's give it a shot. See if you can hear Dr. Bisher through the phone when you're asking questions. That's the problem. And we tried to work on it beforehand. Not sure if I got it worked out. But until then, we will hit a question in the chat room where, let's see, the member, these guys have the funniest or the most creative usernames. It's always day one. That's this guy's name. How much I like how much Dr. Bisher is optimistic about, I'm sorry. His question is, how optimistic is Dr. Bisher about anti-androgen receptor therapies like Cosma RNA, which is a new product that was just released yesterday? It's a siRNA product, if you know anything about that. What can be the potential side effect, which we can think of right now? Do these receptors play some role in the body? Do you know anything about this?
Androgenetic receptor blockers? Does he want us?
Well,
okay.
well, there's a new product called Cosma RNA, and it's an RNA-based therapy where it reduces the sensitivity of the cellular receptors to DHT. So it's a completely new way of treating male or androgenic alopecia.
Mm-hmm. Now, I have to say that I'm so optimistic for the new treatments because now we are just criticizing the androgenetic alopecia for many years. Mm-hmm. And we know that receptors are important, gens are important, and sensitivity of the patient is important. But what we know, just especially in LA meeting, we also discussed it in some presentation. We said that something more than the androgenetic receptor, something more than 5-alpha reductase enzyme, something more than dehydrotestosterone. Yes, we know that. Dehydrotestosterone stimulates the androgenetic alopecia. We know that receptors are important, but we know that although we take all the dehydrotestosterone levels under control, although we block 5-alpha reductase enzyme completely, maybe we think that we have no chance to take it under control. So what we are aware at the end that, yes, this type of medication has high chance to work. We know it. But also we know it in some patients. These medications, they don't work. You know, we use finasteride, dutasteride, minoxidil. In some patients, according to my experience, they really work wonderful. But in some patients, nothing. So at the end, we understand that everything is not related with the dehydrotestosterone levels. There is something more there that we don't know. We have to find maybe some gens, maybe some sensitive factors. But I'm optimistic that in 5 years, I guess, according to my research, I think we are very close to the end. So we are going to handle it in 5 years. This is my estimation, because they are trying to focus on some gens, some enzymes, some blockers. Why not?
Okay.
Why
All
not?
right. So you heard it here first. Dr. Ujlan Bisher predicts that in 5 years, we'll have a cure for hair loss.
I hope. I will be retired.
You'll be retired. Yeah. Okay. That's great, actually. All right. So we did have a call, but they hung up. So let's look at the next question. Let's go to, Milk Drinker in the chat room says, Dr. Bisher, do you prefer FUS or FUE? Strip or FUE for your practice?
No, this is. I think this is a really good question. I perform both of them. I really, I have to say that I really
I'm putting you on hold, caller. Go ahead.
I really like to perform FUT strip. Strip, my my previous years, my youngerhood, I have to say, in the job, in the business, I did maybe thousands of FUT in my life, and it's really good, but it has some disadvantages, and also it has some advantages.
Of course.
Also, I like FUE micromotor, FUE manual. What is my approach to the techniques? I know that micromotor is very fast, very easy. You have chance to increase the graft number. Also, it is sometimes good, it is sometimes bad. But FUT, if you choose the right patient, it really works very well. But I don't want to perform it now for the young guys. Because why? Because it's too difficult to estimate the long-term planning. They may prefer to change their hairstyle. They may prefer to use very short hair, because at the beginning they said that, no, I don't want to change my hairstyle. I will use my hair long. But 5 years later, they change their opinion. So this scar is unreversible. Also, it is seen, we know, but there is a scar all of their life. So if you choose the right patient, if it is Norwood 6, Norwood 7, and if you are going to combine with body hairs, with FUE, with combo sessions, yes, why not? FUT is a great technique also for today. But the priority of mine is generally FUE. Why? Because I think that I have a chance to give less scars to them, and it is less visible. Maybe, according to me, the complication risk is little bit lower than FUT, because FUT is a graft, full flap surgery, so it means that it is little bit more aggressive maybe than FUE. So I compare them, but for some cases, of course, FUT is better better than FUE. So according to me, right technique for the right patient, right technique for according to the expectation. So I choose the technique according to it. But if they need big amount of numbers, FUE. If they don't want to shave their hairs and very small and over 40 years old, and why not FUT? So I have a algorithm while I'm choosing the right technique for the patient, but we discuss generally together.
So, in this is just a genuine question that I don't know. If you were approached by a younger patient, let's say not real young, but we'll say 30-ish in that realm, and they do have indications for, or they're showing indications for advanced hair loss in the future, which route would you take, all things being equal, FUT or FUE, knowing that they'll need multiple surgeries for full coverage as they continue to lose?
Which Norwood is?
Eventually, you can see that he's going to be an advanced Norwood, like say a full-on 5 or a 6. All characteristics, all things being equal as far as characteristics of the patient for either procedure, for the long term, what would you see being the better route to start with, strip or FUE?
No, I'll explain you my approach.
Yeah.
If the patient is, especially last 5 years, I prefer not to perform surgery who is younger than 25. In the society, 21 or 22 is acceptable ages, but my approach is completely, I take it the age a little bit higher. I try to gain time, and I explain this time to them, because really what is important, what I see as many years, long-term planning is everything for young patients, because they think that the hair is important for them because they are young. They think that when you are going to be 40 years old, the hair is going to lose their importance. That's the main mistake.
Yeah.
And the second, if the patient is 30 years old, if he is using medication, if his expectations is okay for going step by step. My prefer is FUE. If he ask FUT and if he when we discuss and if he gives good criteria to me for FUT, I can perform. But if he ask my opinion, my first planning is FUE. Why? Because I have chance to do FUT 5 years later also, but I have to do the front line, and I want to get big amount of grafts as much as possible, and I want to plan the front part first. So it means that I may need around 1,000 grafts. So at least 2,500 grafts for good density with the front line and front part. So FUE is better for me for that case. But when he is over 40 and he is getting Norwood 6 and 7, and if the donor capacity is getting lower, and if I had no chance to extract more by FUE, I may use FUT, then I can do body hair transplantation and cover the scar. So I have some strategies, some approaches, but for the young patient, I prefer to do FUE, I have to say, because they have chance to shave their hairs, they have chance to use different type of hairstyles, and FUT, there is no how can I say, we don't have to stop in an age for FUT. I can perform FUT for 50 years old guy also.
Yeah.
So I don't need to do it when he is young. I prefer to go step by step, and my first priority is FUE. If the donor is limited, why not? We can perform FUT, we can use body hair transplantation, we can use beard, chest, medications, other therapies. A lot of we are so lucky now. We have a lot of options. I have to say, a lot of options.
All right. Okay, that's a good answer. So we'll move on to see if this call works real quick. So, caller, thank you for holding. You're on the main event with myself and Dr. Bisher. Let's see if you can hear her. What's your name? Where are you calling from?
Adam, Wisconsin.
Adam in Wisconsin. Dr. Bisher, did you hear Adam?
Yes, I can hear. How are you?
Okay, Adam, can you hear her?
I don't. No.
Okay, well, she's asking how you're doing. I'm sorry about this mix. I don't know what the hell's going on with my phone system, but go ahead and ask your question if you have one, and I'll let you know what she says.
Well, I'm doing good, doctor. Thank you for asking. I hope you're doing awesome. My question is regarding minoxidil, and I'm taking topical minoxidil. I actually called Joe a few weeks ago about this, but I'm just bringing it up also to her. I've been taking topical minoxidil for years now, and with tretinoin. So I'll apply the cream of tretinoin, and then in my frontal and then my crown. And then I'll let that sit for 10-15 minutes, and then I'll apply my topical. And I haven't had any regrowth with that. I don't know if I could even say I'm stabilizing. I am also on dutasteride. I've been on that for 2 years now.
Okay.
And I've also started taking oral minoxidil, and I take 0.625, so I just quarter 2.5 milligrams. And I was just wondering, when is it safe to get off of topical minoxidil and just continue using oral, provided that I don't get any side effects? I use it in quarters because when I took it in half, it gave me side effects.
Okay. All right, Dr. Bisher, did you understand everything he's asking?
Yes, I understand. Yes, I understand. Now,
okay,
I want to...
Adam. Sorry, Adam. I'm going to hang up so you can listen to the answer on the live stream. Okay.
Okay.
All right. Thanks for calling. Go ahead, doctor.
Okay. Now, Adam, I want to reply your question, but I want to give little bit detailed way. because it may help for others also. What is our approach to minoxidil usage? Now, we know that it works in many cases, but we know that the usage of the topical form is little bit difficult and the tablet form is little bit easier than the topical one. Why? Because if you use the topical one, you have to use it 2 times per day, and if you want to use the tablet form, you have to take 1 time, and for the long term, the number of the time, how many times you take the medication is affect your life. And for the topical minoxidil, the hairstyling, the hair usage, the cleaning may be a little bit difficult, and you may have some, for example, itching problems, some atopic dermatitis in the topical form. So what is important according to me? When you start to minoxidil tablet or spray form, you are going to lose some hairs at the beginning, especially for the first month. So after in the first month, you are going to have some telogen activation. So it means that you are going to lose some hairs. It's not permanent. In 6 months, the density and the calibration of the hairs are increasing. And in 1 year, it will increase and increase and it will stop, generally. And the density will stop in 1 year. It will affect in the maximum capacity. The calibration may be a little bit thicker. The weight of the hair may be a little bit thicker in 1.5 year, maximum 2 years for minoxidil. We know it. So if the patient is using minoxidil for 1 year, and if he says that he sees no benefit, no effectivity of minoxidil, then we have to clarify some points. We have to examine it. Why? Because we have to take it under control in 1 month. Then we have to see the increase in density. We have to see the increase in calibration. But if the patient says that there is nothing, so we have to re-evaluate this patient. Okay, and if you ask me what is the best way, form way or the tablet form, it changes according to patient. I have to examine you. Why? I don't know if you have any hypotension problem. I don't know if you have any seborrheic dermatitis. I don't know of the usage, which method is easy for you. It changes to patient, I have to say. And there is no an exact answer for only one patient. So if you don't see any effectivity related with minoxidil, my suggestion to you, please go to a dermatologist, because in that case, we have to re-evaluate you from the beginning. Okay?
Okay, that's. I think it's a good answer. But what would you say about the last part of his question? He was asking, what's a safe way to transition from away from the topical that he's using to where he's only taking oral, because he's currently taking topical, and he's prepping his scalp every day with tretinoin cream for 15 minutes for the topical application. He's taking the quarter tablet of 2.5 milligram oral minoxidil, and he's taking dutasteride. He wants to wean off of topical. So what would you recommend as far as that approach?
Also, I don't suggest, no, this for him. This is the general information. I don't suggest my patients to use both of them. I choose one of them, tablet or foam way. Yeah. But what I have to inform him, he has to go to a doctor. Please, what is the common mistake? Without examination, without knowing the exact problem, because we know that sometimes the patients has cicatricial alopecias and they think that they have androgenetic alopecia, and without trichoscopy, without examination, without some blood works, they use many years medication, and at the end they got nothing, and they lose time. We miss the cicatricial alopecias, and really they lose their chances. So as a doctor, I have to clarify, this is very important. Please, before going to the doctors, before touching contact the doctors in your country, everywhere we have wonderful colleagues. Go to the dermatologists, go to the hair surgeons. They have to check your scalp. We have to examine your scalp. Don't think that a medication will work in every patient. No. If you have scatocell alopecias, if you have alopecia areata, combined patients, some patients have both of them. So you missed the exact problem. So please go to your doctor, and it's easy to say use, not to use. It's so easy, but we may misinform you, and I don't want to misinform anyone.
Well, there you go. That's a safe answer. I like that one. All right. So there was a question here that I saw from regular participant FSK. He's got a question for Dr. Bisher. How long have you been doing hair transplant surgery on your own, solo? And who did you train under? And how long did you train before you started operating on your own?
Okay. Now, I have my private clinic for 20 years. It means that I have been doing my own hair transplantation 20 years in my own clinic. But I educated from the university more than 25 years ago. It's this year, I guess, 26, or we have to calculate the years. At least 25 years ago, and I started to work in aesthetic society after I graduated from the university. It means that 1998, my first patient on aesthetic and on medical aesthetic, we say. It means that around 25 years I am in the society, but in my own clinic 20 years. Before it, I trained, I worked with some of my colleagues. I performed hair transplantations also there, but with some doctors, with another private clinics, not in my clinics. So 20 years in my own clinic, around 25 years in the society.
Okay. And were there any particular doctors that you trained under before you?
Yes.
Yeah.
Yes.
Have we heard of them? Who are they?
No, of course. Now, if you, how I can explain you, especially for FOE, Alex Gisbrook in 2002, I guess. In 2002, Alex Gisbrook trained me for FOE.
Mm-hmm.
Before it, FUT, in Turkey, we have a plastic surgeon. He was my assistant in the university. I trained in his private clinic. Then I went thousands of clinics, I have to say, in 5 years.
Right.
In Turkey also, we had my first insurance work in a hair transplantation clinic also in Turkey.
Mm-hmm.
And that was the first one in Turkey at that time. So I worked thousands of clinics, and I was so open to ask, and I called them at that time. I mailed them in everywhere, in Europe, in Israel, in Turkey.
You had your own contact campaign to find out where you can go to learn more.
There was no workshop.
Yeah, that's right. Yeah. So you took it upon yourself to seek out education from those that were willing to share it with you. That's nice to hear, because a lot of doctors even today are taking these weekend courses and offering surgery to unwitting patients that think that they're some sort of pioneer, which is ridiculous, of course.
What I did, I can easily say. First, I went. The clinic that I was working, there are some doctors, they were performing hair surgeries, but of course they didn't give me the patient at the beginning.
Of course.
First, I watched them, I assist them for long term. Then I found my patient from my family, and I one day I asked them, I want to do his hair surgery, but I don't trust myself. Please be next to me. I will do everything, but please check me. If I do
Okay.
any mistake, please take me under control. So this story was very long, but it was not easy.
Yeah.
At that time, nobody trusted that the hair surgery will get good result
Right.
because the society doesn't know anything, especially the patients. And I know many patients that they come to me and I said that, okay, we are going to transplantate a new hair suit. And they thought that this is a prothese or just a wig, or they think that this is a waste of money. It was difficult stories.
Yeah, no, I get that. I like the fact that you put yourself out there looking for anyone that would share their experience and knowledge with you. That's the way to do it. So good for you. So before I get to the question in the chat room, I do have a caller on the line, and I will let everyone know that moving forward, you're welcome to call. And the way we'll do this, because of the limitation of the phone system today, you can ask your question. Dr. Bisher will hear you just fine. And then once your question is answered, then you can hang up and listen to her response during the live stream. With that said, let's go ahead and get this call right here. Hey, you're on the main event with Dr. Bisher. What's your name and where are you calling from?
Hi, Joe. This is Norwood Shaman.
Hello, Norwood Shaman. How are you?
Yeah, I'm fine. How about you?
Very good. Did you hear my announcement while you're on hold about how we're doing this with the phone system? You can ask your question and then go ahead and hang up, and you can listen to Dr. Bisher's reply in the live stream. Does that sound good?
Yeah, sure. But I can do it like this because I have a few questions, if you don't mind. I can ask my question and then mute the show and then ask another question, if that's okay.
Well, we can try it, but there's a delay of about 10 seconds, so it might lead to some awkward silences. But let's give it a shot. Go ahead.
Okay. So my first question would be when it comes to the surgeon's transplant procedure. Do the surgeons use sedatives themselves? Because I'm thinking that it requires fine hand motoric skills, and you need to be steady with the hands. I assume. So I'm wondering if the doctors use sedatives themselves.
You're asking if Dr. Bisher uses a sedative on herself before surgery.
Yes, they're calming down the nerves, so to speak.
Got it. She's shaking.
I can easily answer.
She's shaking her head violently. No.
Okay, I wasn't speaking just only about her, but in general, if she knows.
Yeah. Well, I'll go ahead and answer the rest of that question for her. If you find a doctor that's using medication to calm their nerves before they're cutting your skin, run. Run, because there's all kinds of wrong with that one. Well, what's your next question, Mr. Shaman?
Yeah, okay, I'll keep it short. My question would be regarding the medications. Have you when it comes to side effects on certain medications, such as antidepressants, stuff like that, it's known to be toxic for the kidneys, for instance, and the liver sometimes. So I wonder if you can experience side effects with the topical oral minoxidil or finasteride without actually feeling it. The only way you can experience it is by taking, urine analysis or blood tests or anything like that.
Yeah. Okay, Doc?
Now, for minoxidil, I don't ask any liver or urinary system blood works, I have to say. But this is for the routine patient, because if I prescribe a minoxidil or finasteride, I examine the patient, and the patient has to fill the consultation form. And if I have any question mark related with the metabolism, related with the enzymes, related with the urinary system, I have to be careful about them for every medication. But for the minoxidil, I have never heard that we have to ask some blood works. But if the patient has some kidney problems, liver system problems, or something else, in that case, we have to be careful for the medications, but not only for the minoxidil, for general. I don't expect this kind of side effects on minoxidil, I have to say. I have never heard, but of course, what is also critic point, when we prescribed medication, what I do, I ask the patients to come to clinic 6 months later. So I do reconsultation and reconsultation. If I see any problem, then focused on. But that is not my routine. That to ask some blood works or urine system works before minoxidil. But before finasteride, yes, I do it.
Okay.
I ask liver enzymes, but not for minoxidil.
Okay. All right. Shaman, what's your next question?
Okay, my final question is, have you, when it comes to the hair industry, have you experienced, the medicine, it's a constant evolvement, as things change all the time. It's like the tech industry, right? Something that is functioning 5 years today, today, and doesn't work 5 years later. Have you seen such a case that is working today, but it's not working 5 years later?
What do you mean qualify working? What do you mean like a surgical outcome that's continuing to grow, or medication? What are you talking about specifically?
I'm talking about anything regarding the technique, surgical planning, medications.
So, in other words, are there any protocols that seem to be obsolete after about 5 years? Is that what you're talking about?
Yeah, exactly. Anything.
Okay. Yeah. Doctor, what do you think?
No, time will show. Yes, sometimes we say that, for example, 10 years ago, we say that PRP is working so well, for example, or exosome works wonderful, or A-cell is great. Yes, now we say that, okay, the holding solutions are important, but not as much as we thought. Yes, something is changing, we know, but it's so difficult sometimes to see the future. But what we prefer to do, we prefer to go in safety. So when we accept a medicine or a treatment or a technique for the patients, we have to go very slowly. We want to go very slowly. We are open, but we are also careful. Of course, a lot of things may change. I'm really hopeful for the future, but my estimation will be related with the GAN systems, not only for the medication. According to me, they are going to find the exact GAN which stimulates the hair loss. If we have chance to find this GAN, and if we have chance to manage this GAN, we have chance to take it under control. This is my expectation, but we will see. Time will show.
All right, Shaman, I'll go ahead and throw my answer in that. I think that what Dr. Bisher was saying makes a lot of sense, but the way I look at it is nothing really becomes obsolete. It's just there's usually a lot of hype around new protocols or adjunct procedures or adjunct treatments that are introduced. Like Dr. Bisher mentioned, A-cell is one of them. But they're all turning out to be not useless or obsolete, but just not as good as we had hoped. And in some cases, they do make sense. For instance, PRP makes a lot of sense. It just depends on the recipe. Basically, it depends on the centrifuge that's being used. It depends on the platelet concentration. It depends on the ancillary ingredients, or like some of the mixes that they put in, including A-cell. But it's different with every clinic. So the only thing that's really becoming obsolete are just outdated surgical procedures like plugs and things like that. Nothing is really obsolete because there are always going to be cases where something does make sense, unless you're looking at the antiquated surgical procedures. So it's hard to say that anything actually goes obsolete in 5 years. It would take much longer than that, actually, until something revolutionary comes around to really change the game. Hope that answers the question. I need to pop off here and look for some more calls. Thank you very much. All right, so let's jump into the chat room. There's some good questions there. Let's see. Sergey in the chat rooms asks, before I get to the question, I need to ask you, Doctor. It is now 2 a.m. in Istanbul. Everyone, I'd like for you guys to realize Dr. Bisher is up very late in the evening, or you could say very early in the morning. We appreciate her taking the time to answer your questions. Please show her support by clicking like on this video. Show that you appreciate her. And of course, if you're not subscribed, subscribe and ring the bell for all notifications. But let's like this video. Let's get the likes up there so that she can get that warm, fuzzy feeling of appreciation. So yeah, the question was, why did Dr. Bisher choose to work with a motorized punch? Does it provide any benefit over a manual punch besides the convenience for the doctor? That's a good question. Doctor?
No, the punch is how can I say, a topic of whole presentation. I can do maybe 2 hours presentation only for the topic of punches.
Yeah.
Because we have different type of punches, just hybrid punches, just dull punches, sharp punches, manual punches, micromotor punches. Now, what is important for the scars? We know that scar has direct relationship with the size and with the how quick we are. If we really good effort to the tissue at high pressure, at the end of the procedure, my arm is getting tired and the pressure that I gave to the tissue is getting lower. And from the beginning to the end, by manual, according to me, the pressure that we give to the tissue is different, and there is no standardization for the extraction. But by micromotor, I have chance to standardize it, and the second, I have chance to be quick. The third, the effectivity, according to me, is increasing. So that's the reason that I prefer micromotor, but it doesn't mean that that's better than the other one or that's worse than the other one. I use both of them, but according to me, when you compare the cost, when you compare the time, it means that the effectivity, I guess micromotor is better choice for me. Why? They pay less, they got more, at the end the same result. So this is my experience, but many of my colleagues may think different. We have to respect each other. I respect them at the end. So no problem. For me, I can perform both of them.
Okay. That's very well said. Very, very diplomatic for the other doctors that are listening. Let's go to some more questions. And of course, you can call in. It is toll free, 833-563-4247. We got a call right now. Hello, caller. You're on with Dr. Bisher. What's your name, where you're calling from, and what's your question?
Hey there. This is Mike from California.
Hello, Mike from California.
I have 2 super short questions. The first one being, is there a way for these clinics to determine if, I've been on the finasteride for about 5 months now, and so, I'm not sure if I'm having further progression of hair loss or if it's shedding. Is there a way to determine that? And the second question being, how to ensure that if you go for an assessment, be a hair transplant, you get an honest opinion. You're getting an honest opinion from the clinic itself regarding your donor area, because I think that's thinning as well a little bit. Thank you.
So let's clarify the first question. So you've been taking finasteride for 5 months. How can you tell? How can you tell if you're shedding or if you're or if your hair loss is slowing or even reversing?
Progressing. Yeah.
And then the second question is if you go for a surgical assessment, how can you tell if a doctor is honest?
Yes, about the donor area specifically.
Yeah. Okay. All right. We'll get Dr. Bisher to answer. Go ahead and listen in the live stream. Thanks for calling. All right, doctor?
Okay. Now, the first question, he is using finasteride for 5 months.
5 months.
And he doesn't know if it helps or not. And he wants to learn how
he wants to know how can he tell if he's shedding versus having progress, positive progress, regrowth or thickening.
Does he have shedding? No.
He didn't say. And I'll just go and throw my answer in there, but before you start with yours, I think that if you're shedding, it would be obvious that you're seeing more hair in the sink or in the shower when you're washing your hair. Hopefully, you're washing your hair at least once every couple of days. You'd be able to notice these things. And if you're having progress, I think the question is more along the lines of, if you are shedding, does that indicate progress? Does it indicate a telogen that's triggered by finasteride, and will you have improvements after that? So how do you tell that? Well, you can't tell if you're going to have progress after that. The only way you can tell if you're going to have progress is by looking in the mirror. It seems obvious, but maybe take photos of yourself now in a very controlled environment, and then take the same photo in the same environment, say like in your washroom, 5 or 6 months from now. That would be my answer, doctor. What do you think?
No, what is important, while generally my experience, when the patients are using finasteride, generally it works. Although he uses finasteride, and although for 5 months, and if he thinks that his hair loss is still active, so it means that there may be something extra there. And we have to be careful. I think he only thinks that his problem may be only androgenetic alopecia. So we have to be very careful about it. He may have iron deficiency, he may have thyroid problems, he may have the side effect of other medications, just like antidepressants or something else. Mm-hmm. So if his hair loss is resisting, although he is using finasteride, we have to have some question mark in our minds. We have to try to find some extra reasons, or we have to delete some reasons before starting finasteride. Right. That's why I wanted to clarify to all of patients. We have to examine you. This is not only a sentences, because sometimes we find thyroid problems, and when we treat it, your hair loss is completely disappear. Or when you have, for example, iron deficiency, it looks like very simple, but it's so common. And when you give the direct medication to him, the hair loss is stopped. So patients think that the only reason is androgenetic alopecia, and only medication is finasteride and minoxidil, and when they take it, they will take it under control. I suggest him, please go to a dermatologist. Please go to your family doctor, and please ask them to examine you, to check the tissue, to check the blood works, find the exact reason, take the treatment.
Okay, good answer. The second question he had was, and this is kind of difficult to answer, but how can you tell if a doctor is being honest about the assessment of your donor area?
Now, I trust all of my colleagues. That's the only and one answer for me. I have never thought that one of my colleagues in the world, in Turkey or in everywhere, he is trying to misinform you for money, for something else, for no reason. I don't trust this. I trust all of my colleagues. If they cannot evaluate you, it is not related with the honesty. It is related with the maybe experience, less experience, or maybe less of knowledge, but not with bad heart, with bad
malintent
goals.
Yeah, I agree with that, actually.
I don't think so.
That's a really good answer. I think that it has to do with, it's the practice of medicine. It doesn't mean that everyone's going to have the same opinion. I can't count how many times I've I've been with a patient, and we've given our assessment, our being the clinic I'd be working for, and they would say, well, I talked to 37 other clinics, and they've all said that it's that they recommend less grafts than what you're recommending, or some of them recommend more grafts. It's like, well, okay, well there's a comfort zone that different clinics have that they think is appropriate for what your goals might be. If you even said to each clinic the same goals that you have, if you repeated that consistently, like there's so many variables with that. And I also have to agree that I don't, it would have to be a rare doctor that would purposely mislead you on your donor. And I would find that not difficult to believe, but I would find that unusual, because if you are dishonest with a patient about the donor capacity or the donor viability, and you wind up having surgery with that doctor, they're setting themselves up for failure just as much as they're setting you up for failure. And it's an extreme, how can I say this? An extreme shortcoming in their foresight, because it makes them look bad, and especially if you're going to be talking about it. So, I've seen cases where an assessment was made, surgery was performed, and then maybe the donor looked thinner than it should have. But that's not always, that's not because of a malintent, like I was saying. It could be an overestimation by mistake, or it could even be a shock loss issue where the donor just didn't respond very well to the traumatic nature of surgery, things like that. Would you agree with that, doctor? That makes sense?
I wanted to give I completely agree with you. I wanted to give an example to you. Around 1.5 years ago, I started to work with the French patients, and it was my first patient from France. And my consultant was really worked very hard, because no one knows me in France, in Paris or somewhere else, and a lot of patients text me. I trained my consultant, and we checked the photographs together. I trained him very well, I have to say. Then what happened? One patient sent me photographs, and really the photograph, when I saw it, and I said that, okay, he's so young, but he needs at least 4,000 grafts. Oh my God, so young, 4,000, how we will handle? Let's be protective, conservative, take the graft number lower, multiple sessions, and go step by step, gain time. I'm trying to find solutions. Okay, we gave him appointment, and what was the missing? We didn't do online consultation, because he said that he's so busy, and the time we couldn't arrange the time together. He said that no problem, I will come. Okay. When he came to the clinic, what happened? I saw him. I asked him, why you are here? For whom? He said, today I have a surgery with you. Just I opened the door. Why you are here? I said, for whom? For laser, for hair surgery, for medical treatment. Just I asked. He said, you have appointment with me for today. What? He has full of hair. And what I learned after 20 years, 25 years, I learned that he takes the photographs, because generally patients send me the photographs when their hair is dry. He made his hair wet, and I didn't check it, I didn't aware of it, and under the light, and all the skin was seeing in the photographs. And when I see the patient and the photographs, completely different. And what happened? We canceled the surgery. We said that, sorry, you don't need, we cannot touch you. So this type of things may happen. So that's the reason that last 2-3 years, I asked all of my consultants to arrange online consultation with the patient before they come to Turkey. Why? Because photographs may misinform me, patients may misinform me. Because why? They say that, okay, my expectation is this. Sometimes they don't share their health problems. Sometimes the angle of the photographs are different, light is different. So really, all the online consultation, we have chance to not misevaluate, but evaluate very well. We have to check the patient.
Yeah.
So I don't think that the doctors, my colleagues, did make mistake, although they know it.
And for everyone that's listening, so you understand, when she's talking about online consultation, she's referring to a video consultation as opposed to just photos, which makes a lot of sense. And back when I was a consultant, video wasn't so much of an option. It was available, but it just wasn't easy like it is today. And that should be the preferred method as a standard, at least follow up to photos, because in photos you can tell, okay, any sort of big issues, and then you follow up with a video, and then the whole 9 yards. So I think that's a good answer, and it's a great story to go along with that, to reiterate that it's important to understand that you're just relying on photos and information remotely, where the ultimate is, if you can't do video, or if you can't do in person, is video. That makes a huge difference. But back to the original point of the question, yeah, I don't see any. It would be a really unusual individual that would purposely give a false estimate of the donor area. I hope that answers your question. Before I answer this call, Dr. Bisher, how much longer are you available? We've got 45 minutes left in the podcast.
I'm available for you. How long you want? Please feel free. However you want. No, I'm ready for
everyone in the chat room and or in the audience watching this. Please hit that like button to acknowledge what this doctor is doing for us. It is 2:18 a.m. in Istanbul right now. Is that the right time? 2:18.
Yes, I think so. Let me check. Yes.
Wow. Okay. Yeah. So thank you again for coming on. I know that my subscribers really appreciate it. Let's get to the phone call. Hello, caller. You are on the main event with Dr. Bisher. What's your name? Where are you calling from? And what is your question?
Hey, how you guys doing? My name is James. I am from New York State.
Hello, James.
Hi. So my question is I have gotten a quote of around 2,700 grafts for my frontal third, a little bit going into the mid scalp. I'm a little hesitant to do surgery now because I still have native hair.
Uh-huh.
It's not dense, but it is combable with Topic. I'm able to pull off a good look.
Okay.
However, it's relatively miniaturized if I look under a microscope, but I don't know if I should wait till the hair falls out further or just do the surgery, because what I'm concerned about is having, the hair that I have now be shocked out.
Mm-hmm.
And the hair, and then the transplants just stand alone, and it kind of looks how it does now.
Are you on medication now? Preventative medication, finasteride?
I am not.
Okay. Okay. So I'll let Dr. Bisher give her answer. We're going to hang up. You can listen to the live stream, and then I'll follow up with my thoughts. Okay.
All right. Thank you.
Thanks, buddy. Dr. Bisher, what do you think?
Can you summarize his question to me, because most is not.
Yeah, sorry. Yeah, so his question was he's been assessed at needing 2,700 grafts for a procedure, and he's not sure if he wants to move forward with it because, and this is going to be in the recipient area of the hairline to the frontal mid scalp, so not a huge area, and he has enough hair that he can still comb it, and he can get by using Topic without any sort of issues. His concern is permanent shock loss of his recipient of the recipient area, so he's concerned whether or not he should actually have surgery. What are your thoughts?
Okay. How old is he?
He didn't. He didn't state, but he sounded like he's at least 30.
Is going to change it. Okay. Now I will give a general answer to him. I think it will be helpful for everyone and also for him. Now, what is my approach? For the young patient who is younger than 30 years old, generally when they are Norwood 1, Norwood 2, sometimes Norwood 3 also, I say that please wait. If they are Norwood 1, Norwood 2, Norwood 3. Why? Because if they have chance to wait, I ask them to wait and see the progress. This is my general approach who is younger than 30 years old. And what I also tell to them, this is very important, Joe, for me. This is my motto. The best is the enemy of the good in aesthetic. If your hair is good, this is my general advice or suggestion to you. If you can tolerate your life with your hair, please, and also if you are younger than 30 years old, this is my approach. Please try to come to us as late as possible because you are going to lose your hairs. You are going to need multiple sessions. And what is the tricky point? Your donor is limited. Long-term planning is important and we need to go step by step. If you lose your hairs, we need to find some reserve on your donor for the future. And when you come us late, it's better for you, not for us. We have chance to help you to tolerate your life for long term. But if this patient is 45 years old, it means that my approach will change. What will happen? I say that the risk of androgenetic alopecia is decreasing. So your hair loss may be stabilized more than before. So if still the Norwood 2 bothers you, we have chance to help you. Okay? Because your risk is decreasing and maybe one session or two sessions will completely enough for you. And if it still bothers you, why not? Let's do it. But for 25 years old guy, for 27 years old guy, I ask them try to tolerate their life as much as they can.
Okay. I like that. Let's see. So I was going to say something about that. Oh, yeah. So my position on this caller is you're not on preventative medication. I think that you should postpone surgery until you've been on preventative medication for at least a year to see how you respond to it. Because you're not bald. You said that you have some miniaturization going on. I would avoid surgery entirely, like Dr. Bisher said, for as long as possible, but at the bare minimum for a year so you can see how medication works for you. If you were to tell me that you've tried it and you're having side effects or you're afraid of side effects, then find a doctor that can prescribe a topical formulation of finasteride. That's the industry standard, is finasteride. There are other options out there for you. But give that a shot and see how that works out. There's actually a really good chance that after a year of use, you might look in the mirror and say, I don't even really need to use Topic anymore, much less need to have surgery. So I would recommend you try that and call back into the show and let me know how you're doing and what you think about it, okay? So I hope that helps.
I want to add one small thing.
Yeah.
Hair surgery is not the treatment of miniaturization. This is very important.
Yeah.
If you have miniaturization, there is treatment. If you have hair loss, big recipient area, then we have chance for hair surgery.
Yeah.
But the hair surgery is not the treatment of hair loss or hair miniaturization. This is something else.
Yeah, well said. Well said. Yeah, that was good. So toll free, 833-563-4247. That is toll free in North America, 1-833-563-4247, and accessible worldwide through the calling app of your choice. We are live with Dr. Özlem Biçer from Istanbul, Turkey, and she's answering your questions. What we've got going on with the phone system is you can call in, you can ask her the question, hang up, and listen to her response in live stream because you can't hear her through the phone system. I got to get that fixed. But let's go to the chat room. We got a lot of activity going on in the chat room. Appreciate that. And we got a phone call. Okay. And looks like from the same area code as before. What's your name and where are you calling from? What's your question for Dr. Bisher?
Hey, this is Mike from California again.
Hello,
thanks
Mike
for
from
that answer
California.
on the previous question.
Yeah, okay.
I had another follow-up question. The explanation was really insightful. So, I've been taking some photos, but they're not really conclusive as in my hair loss is progressing or not. I've been taking the medicine as well. Do clinics have a way using some equipment to decipher if your hair is starting to improve from finasteride? Is there a test as such that you can get from these doctors who would be able to make a certain judgment? Okay, that the medication is working on you.
Mm-hmm. Yeah,
Yes.
absolutely. So let's go ahead and pop you off here and let her answer the question. And yep, there he goes. Okay,
Yes,
go ahead.
we have some equipments. We can measure the calibration of the hairs. We can measure the density of the hairs, and especially for the donor area, it's easy to assess. Also, we can use it for the recipient area. How many hairs he has per centimeter square? What is the calibration for the donor and for the recipient area? But I have to say that hair loss is not only for the donor, for the recipient area. These may be sometimes with telegenefleum. These may be sometimes with androgenetic alopecia. So the answer is more, I have to give it more detailed way. It's really very technical, but we have chance to measure a lot of your parameters, and these are really very standardized way, and just we have some meshes for that, and it's clear. But hair loss is generally more dramatic, and the patients are aware of it easily. It is not, how can I say, very silent. And
Yeah.
generally, patients have panic when they have it. It may be very aggressive, it may be silent, but if it is silent, it may be more dangerous. What is my experience? If the patient does not see any hairs on the pillow or on his shoulders, and if he thinks that he is losing his hairs, these kind of patients progress may be more aggressive than the other one.
Yeah.
Because they are not aware of it, and it is more homogeneously more aggressive generally.
Yeah. I think, I mean, that's a great answer. I tend to keep things simple, where if it's a situation where you need to have micro measurements of hair shaft diameter and hair counts to determine, to tell you as a patient if it's working or not, then I kind of look at it like this: is, this is an aesthetic issue. So after, say, a year of use, do you want to be able to see on the micro level that it's working, or would you rather see some sort of aesthetic benefit where you're looking in the mirror and there's no question, or when you're looking at photos over time that you're taking at, say, 1 month intervals for 1 year, where you can see a marked improvement? I think that's a better gauge of whether it's actually working for you or not, because that's what it's all about. If you can visualize degradation or visualize progress, that's what matters. I mean, we want to be able to know for sure. I understand that. And I know plenty of people that are very particular about the nuts and bolts. They do want to know those kinds of details, and it makes sense. But never forget, this is an aesthetic situation that you're dealing with, and a progression of photos should tell you over time. And you said in your call that you're having a hard time telling, well, that at the very least tells me that it's working in maintaining your hair. And I think that's a win. Like that's basically what most people should want, to stop the hair loss from getting worse. And if you get any sort of improvements, that's just bonus. That's gravy, as we say. What do you think? What do you think about that, doctor? You agree with that?
I completely agree with you.
Yeah. Okay.
You
See.
you are really very experienced. Sometimes I feel you just like your job is different. You had to be a doctor. You would be really a great doctor. I'm sure about it.
You heard it here first, people.
You know
Dr.
more than
Bisher
us.
says I make a great doctor. I appreciate that. Thank you, doctor. I'll leave that part to you, though, okay? Let's see. Looking for questions in the chat room. And, of course, you can call everyone. It's toll-free, 833-563-4247, toll-free North America and worldwide from your calling app of choice. I'm surprised we haven't heard from Adrian in Australia. He should be waking up about now. It's about 7:30, I think, in the morning. And he usually calls in on the Bald Truth on Fridays, so maybe we'll hear from him tomorrow. But I know he's a huge fan of yours, and I'm surprised he hasn't called in to say hi. But who knows? Maybe he's still sleeping in. Let's see. Looking for some questions here. Okay, David Hutton asks, Dr. Bisher, what are the maximum grafts you would perform in one surgery? Doc?
No, no. My prefer is around 3,500 grafts. My maximum score in my life, 4,200, I guess. I remember, and this was by mistake. And why? Because while I was doing extraction, my nurse was counting, and just she said that, okay, now we didn't pass over, just according to our plan, the density was good, and my plan was 3,800 or 900, but at the end we saw that our graft number is 4,000, more than 4,000. But this is one patient in 25 years.
Yeah.
And for FUE, one patient for 15 years, maybe. So generally, my approach around 3,500 grafts, because I prefer to perform the hair transplantation who is over Norwood 3, Norwood 4. So this kind of patients needs at least 3,000 grafts generally.
Yeah.
And if you want to get good result, you really need to have a big amount of grafts. But I don't want to go further than 4,000. Generally, my limit is, although he needs more, I prefer to stop maximum in 4,000, but not less than 3,000. I don't prefer to perform. Sometimes if he is Norwood 2, Norwood 3, yes, 2,000 around, but 3,500, more or less 300 is my general graft number.
Limit. Okay, that makes sense.
Generally, I go between them, generally, for a lot of patients.
I
More
wanna,
or less is very rare.
I want to note for the audience, you will never hear a doctor admit publicly on a live stream broadcast about any sort of mistakes that they've made. I thought that was very transparent of you, Dr. Bisher, and very, very human of you to admit that there are a couple of cases where there's like a miscount because of a miscommunication on staff. And yeah, obviously it's very rare that it happens, but I was listening to you say that, and I thought how generous you are with your information, with how that, you're not perfect, you're human. And I don't think I've ever heard a doctor admit to some sort of mistake like that in a public format. So I'd like to thank you for that, because I think it's important that patients understand that fantastic doctors can make mistakes. And you were just talking about that, and it's important. Like, we all know this, but very few doctors, I don't know if any doctors actually talked about their own shortcomings in specific cases in their history. So I just wanted to comment on that. I think it was very, very big of you. Thank you for doing so.
Thank you. No, as you said, I am human, I am not God. What I know for myself, when I look at the mirror, I can look at the mirror very happily. That's what's important for me. When I look at the mirror, I say that, okay, I did my best. And it's very clear that I shared it with my patient at that time. I said that you are lucky, I guess. My plan was to stop at 4,000, but by mistake, we extracted 4,200. And I have to say, it's not secret, but I can share it easily with you. At that time, my plan, for example, if it is 3,800 or 900, I don't remember exactly. And I couldn't sleep all night at that night. Why? Because I passed my limits. By mistake, yes. I wanted to stop in 4,000, but we go further. The density was a little bit higher than my expectations, and I didn't sleep all night because at that time I thought that if I go further than 4,000 in my mind, I have high risk for the complication. I waited all night. Next morning, checked the patients. There was no complication. I prayed to God. We are doctors. We live. Don't think that if anything happens during the procedure, we say that, okay, no problem. Tonight we are going to go to the party. No. Doctors are not this kind of people. Really, we cannot sleep.
Yeah.
Really, we are worried about the patients. We are worried about the team. We are worried about our results. We are worried about the family that they have. And what happened now after the years, we saw that some of our colleagues could easily extract 6,000 per day. But at that years, our maximum limits were 4,000. And I thought that if I go one more 4,000, I will be in the big complication risk.
Yeah.
Yes, but these kind of things may be lived. We are open to the patients. I shared easily. If I do mistake, I also share it easily. But I try to not to do the mistake. That's what is important.
Of course.
Try to take everything under control. But this is life, and I think these are not big mistakes.
No, I agree, but it's still refreshing to hear. So I thank you for sharing that information. It's nice to hear. We do have another question in the chat room from Sergey. What is Dr. Bisher's safe upper limit for density of implantation that ensures good graft survival? That's a good question.
No, this is very balanced. We have to answer this question in a very balanced way. If you want to give good result, the patient wants to have high density. If you want to give it means that you are going to take high risk for survival rates maybe, or for risk of necrosis, for risk of a lot of complications. So I prefer not to go lower than 35 generally. And I prefer not to go further than 60, 65. So it changes which parameters, the blood circulation of the patients, age of the patients, health problems, especially diabetes, hypotension, hypertension, and dermatologic problems. If everything is under control, if the patient is young, if he is supportive, if the blood circulation is wonderful, if the graft quality is okay, I can easily increase the density. If I see any problem, you can easily understand when you check the tissue. You can easily understand the blood circulation. So it changes. Sometimes I decrease the density and I inform the patients and I say that, sorry, I couldn't go further than this. We need to do touch-up. This touch-up, and especially I say that without any charge, because this is not his fault and this is not my fault. And he needs a touch-up without any charge, and I inform him at the end of the surgery, just when he comes to my room, after the surgery room, I inform him about the density and easily say that we are going to do a touch-up to you 1 year later. You have to come here. You don't need to pay anything. We can handle it like this. But sometimes we do 60 grafts per centimeter square. Survival rates may change. Sometimes 55 of them are alive. Sometimes 60 of them are alive. Sometimes 40 of them are alive. In the LA meeting, my presentation was on the poor yield hair transplantation, the reason of them, the causes of them, because we have chance to take under control some parameters, but we don't have chance to take under control everything. So we can take under control what we know. If we don't know some details, we have no chance. So But what we can do, we are here. I am here for my patients. If anything happens, no problem. What is important? They have to obey the rule. I have to obey the rule. If any problem related with the density, we are here just to improve it. No problem. They have chance. So no need to pay extra money. No need. These touch-ups are without charge, I have to say. Up to 500 grafts in my clinic, these are without charge.
I think you've just shot to the top of a lot of people's list of doctors to consider because of what you're sharing about that. That's very generous of you. Yeah.
No. This is the medical treatment. We cannot give guarantee. Everything is not their fault. Everything is not our success. If anything happens, what is important for me? For example, you are driving a car. You may have an accident. You may drive wonderful. If you drive a car every day, you may see every type of patient, every type of cases. So what is important? How to solve the problem is important. So the density, yes, everyone will ask the maximum density. But if your tissue is not available for it, if your donor is not available for it, if we need to improve it, what we talked at the beginning is clear, and I give the direct information to the patients, and I say that you may need the touch-up, you have to come. You may need the second session, you may come. And these are different parameters. What is touch-up? What is session? Why we do touch-up? Why we do session? So I clarify everything. I try to clarify at the beginning. If anything happens more than our estimation, of course we are here to find the solution.
Okay. All right, fair enough. That's very thorough. I enjoy that answer. There was another question. I don't remember who was asking, but I remember seeing it. They wanted to know. You were talking about body hair earlier. What is your experience with body hair, chest hair and beard hair? How often do you use it? What are your feelings about its use in surgery?
Now, I have been using body hairs for many years. I have to say that Turkey is really very good at hair transplantation, and I don't know when I started to transfer chest hair, maybe more than 10 years, maybe just from the beginning. Mm-hmm. We transplanted from the main donor, and also we started to transplantate from the chest for many years. But from the beard, I started to use beard transplantation, I think for 5 or 6 years, because I afraid that at the beginning this area is little bit, I thought, riskful. But then in some meetings, when I shared with my friends, I saw that it's not as riskful as my estimation. And so I started to perform the beard also. Now, it's not very rarely. Every month we have at least one case for body hair transplantation, at least. Sometimes 2 cases, not 3, I guess. But it's good option for the Norwood 6 or 7 patient, I have to say.
Are you using this for augmentation of scalp hair transplants to mix in?
Yes. And now what I learned in LA, I have never done it, but there are some plannings for the future. I have never used, for example, back hairs or arm hairs or leg hairs, but Dr. Umar, he is one of the best, I have to say, in body hair transplantation. I can easily suggest my patients to go to him for deep body hair transplantation because he extracts from everywhere. He extracts from the axillary area, pubic area, back. I don't extract from there. I extract only from chest and arm. But now we talked and he said that there is no difference. You can easily extract from that because you used to do it. So, of course, we are going to improve the body hair transplantation also for many other areas. But they can touch in contact to Dr. Umar. He is really good, and they can ask help from him. Tell my best wishes to him.
you just made there's a guy in the chat room named Rob Hellner. you just made his day because that's his doctor. It's his favorite doctor. So by you saying that, you just made his day. My question though, and this is a discussion that we had the other day on a previous episode, is how are you finding finasteride affects the results of a hair transplant when body hair is used? And I ask that because we know that finasteride affects body hair growth. I know that there are some doctors, maybe even Dr. Umar, if I'm not mistaken, he recommends not using finasteride if you've had a significant body hair transplant. What are your thoughts on that?
Now, again, I have to say that it is related with the age. If the patient, when we use body hair transplantation, we use it for the terminal patient, for the marginal patient. If it means that if he has no chance from the main donor, if he had previous sessions, and body hair transplantation is the last options for us. And when we do it when the patients are at least over 35, at least, because up to the body hair transplantation, we are going to use a lot of options, medications, main donor first, main donor second time. We have no chance in the main donor, then we come to the body. So it means that the patient's getting older, more than 35. And what is my approach? If the patient is more than 35, 40, 45, this is my experience that the medication is not generally necessary for these patients, because we prefer the medications for the young patients, because we know that androgenetic alopecia is maybe very aggressive for the young guys, and the aggressivity of the alopecia is decreasing related with the age. So if the patient is over 35, 40, generally they don't use it. So I don't say that you have to use medication for this patient, but if they want to use, they can use it, because we also transplanted the main donor hairs there, so they may need to protect them, but we have to decide together age, hair loss activity, hair calibration, the genetic pattern. A lot of factors are important for deciding, not directly body hair transplantation main donor.
Right.
A lot of factors I have to consider.
Very good. So there's a question, no one was asking this, but I know it's something that I think people would like to hear from you. So you perform surgery in the most competitive market on the planet, Istanbul, Turkey. And there are thousands of people that go every week, tens of thousands of people every week that are going to Turkey.
Yes.
My first question is, currently, how many clinics do you estimate? And when I say clinics, I don't mean like a real clinic, but destination. How many destinations do you think there are in Istanbul alone for patients that patients are going to today?
At least 1,000, at least.
In Istanbul, that's what I've been saying. And to the viewers and listeners, we didn't talk about this, but that's what I've been saying, because back in 2015, on my first visit, I was speaking with our mutual friend Emre Karadenez, and he was saying that at the time there was about 500 in Istanbul, and over the past 8 years, almost 8 years since that time, I've come to the conclusion that it's doubled. It's 1,000, and you agree with that. So that's nice to hear, but it's also very disturbing to hear. But what would you tell patients that are considering Turkey, your home country, your wonderful home country? I love Turkey. It's fantastic. But how would you warn people that want to come to your country for surgery?
No, I want to tell one thing to them. Please trust doctors. Whoever is not important. If he is doctor, I trust him with all of my heart and all of my brain, because I know how much labor they give, how much time they give, how much effort they give for you. So we have to trust our colleagues. Okay? What I can tell easily to you, please touching contact to your doctor directly. You don't go to have cardiac surgery without a doctor. You are not going to decide for your cardiac surgery or for your sexio or for your appendicitis surgery with an assistant. You go to the every type of medication with your doctor. Why not for hair surgery? So if you are touching contact to doctor, I am sure that you are going to be in safe. Your result may be 10, your result may be 90, but you are going to be in safe. This is our priority. So touching contact to your doctor, ask your questions to your doctor, clarify your expectations with your doctor, and what you want, share with your doctor. What you accept, what you cannot accept. And think that I'm sure that all of them, all of my colleagues, will try to help you as much as they can. I'm sure about it.
That's interesting to hear. I think that's no, that's it's almost like a message of hope if you do things the right way by making sure you talk to your doctor. I like the analogy of you're not going to have heart surgery after only speaking to a consultant. I like that. That's if you don't mind, I'm going to steal that for my future discussions. I think that's a great way of looking at it. To at least make sure you've spoken to your doctor. I like that. Let's see. So let's do one more question here. It's 4:52, 2:52 a.m. for you. So Tinus in, I'm not sure how to pronounce that. Says, hello. Are all Istanbul hair clinics run by Turks or foreigners as well? Does Turkey Istanbul attract foreign hair surgeons? That's a good question. I don't know. Are all the clinics in Istanbul owned and operated by Turkish citizens?
No. Unfortunately, no.
Okay.
Now the society is now crazy. Now you can find Turkish doctors, foreign assistants, foreign doctors, Turkish assistants, combined, or only the foreign. Now you cannot control some black market, I have to say. But what is in black market? I think that's important questions. If you are not working in a legal way, it means that that's black market. If you don't have any license for the clinic, if you don't have any license for the doctor, if the doctors are not in the clinic or are not in the surgery room, are not performing the surgery for you, it means that that's something else. So you can find every type of clinic in the world now, not only in Turkey, I have to say, easily. Everywhere. Now when we come together with the colleagues, we discuss. Now we know that in England they have black market, unfortunately. In Germany, some nurses are going there and perform surgery. We know it, we heard it. In Saudi Arabia, same. I'm sure that everywhere, if they have chance, they want to perform, they want to act just like a doctor. That's the problem. They want to act just like a doctor, but it's not easy to get responsibility of the patient. You can act, but you cannot take the responsibility. There is big differences.
Are you seeing, as far as the nationalities that are coming into Turkey to act like a doctor, pretend like a doctor, or actually are doctors? Are you seeing a concentration of what? Romanians, Hungarians,
No,
Germans?
this is not like, this is not for the doctors, what I tell. This is for the technicians. They may act just like a doctors. Doctors are doctors everywhere.
Right. Okay.
Although they are from Romania, although they are from Bulgaria, these are doctors.
Well,
I have no problem with the doctors.
You're saying that there are people coming in that own the clinic, run the clinic, and there's foreign national doctors and technicians. So the doctors, where are you seeing the doctors coming from?
No, there may be doctors from Iran, from Syria, but we have no problem with the doctors.
Yeah, no,
If the
fair
doctors
enough.
are performing, no problem. But the problem is the technicians. Although they are from Turkey, although they are from abroad, if they try to perform hair transplantation without any doctor, there is the problem. Nationality is not important. Every type of nationality you can find everywhere. You can find Turkish doctor in United States, Iranian doctor in Turkey. It's not important. Nationalities are not important for me.
Are you aware of Turkish companies moving into Mexico to set up?
I know.
It's fun.
I know.
It's funny because you can like I'm seeing it. You know, every few days I'm online looking at different clinics, and I'm seeing Turkish names on these clinics, but they're in Puerto Vallarta, Mexico, or Cancun, and
I know.
yeah.
They ask me. They also ask me. They ask me to send my nurses. They ask me
Oh.
to go there. So it's not secret.
So we might be seeing Dr. Bisher operating in Puerto Vallarta.
No. They have to come to me.
Okay,
So sorry.
so the only thing you'll be doing in Puerto Vallarta is having your cocktail on the beach. Okay, I get it. I don't blame
Yeah,
you.
my nurses are going to do.
Yeah. All right. So I think that's a great place to wrap it up. I'd like to really express a deep and warm thank you to Dr. Özlem Biçer. Am I saying that right?
Yes, of course.
Yeah. Okay. So
You are right.
it's not Özlem Biçer, as everyone says in the Western world. It's Özlem Biçer. And thank you so much for coming on the show and for staying up so late. And also thank you to your husband for putting up with this. I know that he's been coming in and out of your room there. But
he fall down asleep while he was watching me.
there you go. All right. That's the only time, I'm sure. But thank you very much for coming on board. And everyone in the chat room, please say thank you in the chat room now to Dr. Bisher for taking the time out of her early morning where she needs to get back to sleep and to answer your questions. I think it's very generous of her, and I hope that she'll come back. And it's certainly been fun for me, and I hope everyone out there enjoyed it as well. I hope you enjoyed it, Dr. Bisher, because it was quite nice to have you here, and look forward to having you back soon.
Thank you. I really appreciate what you do. I want to thank you. Thank all the attendees, all the questions. I hope I could explain what I want to do. I helped. Thank you so much.
I'm sure everyone got a lot out of it. All right. Thanks, everyone. Thanks for watching. Bye-bye.
Bye.